morning, everyone. Thank you so much for the organizers for inviting us to speak here today. So I'm Evan Laptop from the University of Pennsylvania, and it's going to be my pleasure to moderate this session focused on antibiotic resistance, with really a focus on understanding data that's come more recently from epidemiologic studies that will hopefully serve as the underpinnings for more advanced policy solutions in addressing the emergence of resistance. So I'm going to spend a few moments talking about the antibiotic resistance crisis in general, and then we'll turn it over to three speakers, Jeff Gerber, Susan Wong, and Mike Lin, who will tackle various areas of recent epidemiological research focused on the area. So at the risk of, I hope this isn't going to be too low level, but I thought it would be useful to have a few key terms before we start, just to make sure that we're all sort of on the same page. So when we talk about, and these will be terms that come up frequently throughout the presentation. So an antibiotic, we're going to refer to as any drug that inhibits a bacterial organism. When we say something is resistant, that means that at typical concentrations in the body, an organism is not going to be killed or inhibited by the drug that we're using. So it's resistant to the activity of that drug. And when we talk about different types of organisms, we typically lump them into a number of groups, but the two primary groups that we'll be focusing on are gram-positive and gram-negative organisms, and that's really based on laboratory characteristics that evaluate the cell wall characteristics of organisms. So gram-positive organisms, the ones that we worry about the most from an antibiotic resistance standpoint, are Staphylococcus species, especially Staph aureus, Streptococcus species, especially Strep pneumo, and Enterococcus species. From the gram-negative standpoint, we worry a lot about the Enterobacteriaceae, and that includes a whole lot of different bacteria. The ones that are typically most common are E. coli, common cause of urinary tract infections, Klebsiella pneumonia, another cause of urinary tract infections and pneumonia, and Pseudomonas and Acinetobacter, two even more virulent organisms that also fall within the gram-negative spectrum. And even though there are some types of infections that we typically associate with these organisms, these are really bugs that can cause all sorts of different infections, as indicated by the graphic. There are a lot of different mechanisms of action that antibiotics employ. And there's some antibiotics for which we don't entirely understand the mechanism of action. But depending on which antibiotic you're talking about, they may work at the level of cell wall synthesis and inhibit the ability of the organism to synthesize the wall. It may work at the level of DNA replication, inhibiting the ability of bacteria to multiply. It may act at the level of protein synthesis or at the level of other key functions of the bacterial organism. So while there are a number of different mechanisms, there are an equal, if not greater, number of mechanisms of resistance. So it has not, in general, taken long for bacteria, once exposed to a particular antibiotic, to elaborate a number of different types of mechanisms to get around what we're throwing at them from the antibiotic standpoint. And they can do this by altering their cell membrane. They can do this by regulating things that are called efflux pumps. So if an antibiotic gets into the cell, it can pump it out. Bacteria can develop enzymes that degrade antibiotics. So while there are a number of resistance mechanisms, and by the way, one bacteria isn't limited to having just one mechanism of resistance, it can have multiple, which often confers a multi-drug resistant phenotype to the bacteria. So this is a rendering of the timeline of antibiotic development. The antibiotic era is in fact less than 100 years old, so we haven't been in the antibiotic game for really that long. The top of this schematic shows the years during which various classes of antibiotics were developed. And the bottom shows when the first organisms that were resistant to that antibiotic were identified. What you see from this timeline is that it didn't take long after the introduction of any given antibiotic into the marketplace to start seeing organisms that were resistant to that antibiotic. And this has really been an almost uniform pattern over time, suggesting that the development of new antibiotics as a sole strategy for dealing with resistance is not going to be a viable strategy. There are a whole host of studies that have looked at longitudinal trends in the emergence of antibiotic resistance. These are data for the Enterobacteriaceae, again, things like E. coli or Klebsiella, showing marked increases in resistance over time to a variety of different classes of antibiotics, including the cephalosporins, penicillin derivatives, and the fluoroquinolones. And almost for any bug-drug combination that you might choose to look at, if you look at the last 10 to 20 years, this is the sort of graph that you're going to see, and I'm sparing you all of the other graphs that I could put up, because this is really representative for what's happened in the field of antibiotic resistance over the course of the last 15, 20 years. As I mentioned, one of the strategies historically has been to identify novel antibiotics, or even better, novel classes of antibiotics to deal with resistant organisms that are plaguing us. And what I suggested is that that's not a good long-term strategy, and that's true both because bacteria tend to get resistant fairly quickly, but also because the development of new antimicrobials has slowed considerably over the course of the last 15 years. There are a variety of reasons for this that are both financial, that are technological, because the ability to identify novel mechanisms of action is becoming increasingly challenging. The easy antibiotics to develop have already been developed. And most of the new antimicrobials that are hitting the market now are really minor tweaks of existing antibiotics. They don't really represent a sea change in novel approaches. So what's the landscape of antibiotic resistance? I'm going to focus here on the inpatient setting, because this is where most of the epidemiologic data have come from. If you get admitted to the hospital, you have about a 10% chance of developing an infection while you're in the hospital. That happens to upwards of about 2 million people a year just in the U.S. About 2/3 to 3/4 of those antibiotics, of those infections, are going to be caused by bugs that are resistant to at least one antibiotic, and often multiple antibiotics. So what this has resulted in is an unbelievable cost to not only the healthcare system, but to society in general. This isn't lost on a variety of bodies that span not only the United States, but globally. So this was one representation of that United Nations meeting on antibiotic resistance late last year, about a year ago, which is really only the fourth time that the UN had specifically addressed a given health issue. What this resulted in, after a fair amount of debate on the emerging trends of resistance, was a landmark agreement signed by 193 countries focused on combating global rise in resistance, because this isn't just a U.S. problem, it's not just a European problem, this is really a global problem. And this is in part recognizing the global impact of antibiotic resistance, upwards of almost 1 million deaths annually globally, currently due to resistant infections, and if nothing further is done to deal with it, upwards of about 10 million in 30 years. So what are the pathogens that we're talking about? And I put these up here, not that this is the absolute list, but this is the World Health Organization list, and it's a reasonable representation of the most critical pathogens. And these are the ones that you'll hear about more in the subsequent talks. Over on the left, the most critical, Acinetobacter baumannii, which I mentioned before, one of the gram-negative organisms resistant to carbapenems. Carbapenems are a penicillin related class of antibiotics that typically physicians will keep in their back pocket, so that if you have somebody in the hospital, often who's been in the hospital for a long period of time, who now has a resistant infection, carbapenems are typically the class of antibiotics that we'll go to try to treat them. So when an organism becomes carbapenem resistant, it effectively knocks out almost every treatment strategy that we have for trying to deal with that infection. So carbapenem resistance is a huge problem. Same goes for Pseudomonas for exactly the same reasons. Enterobacteriaceae can be both carbapenem resistant and produce other enzymes. ESBL stands for extended spectrum beta-lactamases, which are broad spectrum enzymes that deactivate a variety of the typical antibiotics that we use in the hospital setting. High priority, perhaps not critical, at least by the World Health Organization standards, vancomycin-resistant Enterococcus, which is a frequent cause of bloodstream infections, and to a lesser degree gastrointestinal infections. Staphylococcus aureus, methicillin-resistant staph, or MRSA, has been around for decades, more recently expanding much more into the community setting versus just the hospital setting. Represents an issue both for the critically ill in the hospital and even for previously healthy young people in the community setting. It can be very virulent with few treatment options. Clowns streptococcus pneumoniae, the right column, the most common cause of community-acquired pneumonia, increasingly resistant to the first-line agents that we typically use to treat pneumonia. And this is a real problem because the diagnostics for pneumonia are challenging. So often we don't exactly know which organism we're targeting when we treat somebody with pneumonia. In fact, most of the time we don't. So if there's increasing resistance, we may not know it until somebody fails to respond to initial therapy. So we really have the very real potential of returning to the pre-antibiotic era. As I mentioned, the antibiotic era itself has only been around for fewer than 100 years. But given the breadth and diversity of resistant pathogens that we're dealing with now, we increasingly encounter patients with infections, particularly in the hospital setting, where we really don't have a viable antibiotic to use. And then you're left scratching your head trying to figure out what sort of strategy am I going to use for this patient, and it really becomes a case-by-case, very difficult decision-making process. So what is clear is that we need better evidence to help us figure out how to deal with the emerging problem of antibiotic resistance. And for many years, the epidemiologic studies that you really need to better inform the strategies that we use to deal with resistance were non-existent. So most of the recommendations that were out there were primarily based on consensus panels, expert opinion, and so forth. It's really only been recently that more work has been done to better define not only the primary drivers of antibiotic resistance, but also to start testing those interventions that may work in curbing the current trends in resistance. Because if we don't preserve the antibiotics that we have currently, as I showed before, the ability of development of new antibiotics to address the problem is really not going to be viable. So I will lump the three categories of primary targets for potential intervention here, and that will dovetail nicely into the next series of talks. Antibiotic use is the primary driver of antibiotic resistance. We use antibiotics poorly, we overuse them, we use them in situations where we shouldn't, and a lot of the epidemiologic data to date has backed that up. The challenge is figuring out how to address that and how to get people to use antibiotics better. If you're exposed to another person who has a resistant organism, these organisms that are spread typically very easily from person to person. So that requires that we know who is infected or colonized with a resistant pathogen and how do we prevent that sort of spread from happening. Finally, in an increasingly global population, not only are patients transferred frequently from the hospital to a long-term care acute hospital, to a skilled nursing facility, to a nursing home, back to the hospital, oftentimes across health systems within a given region. So dealing with resistance only in your institution isn't going to solve the problem. We really need regional and even global approaches, as these are pathogens that transfer very quickly from one region to the next. All of those will be topics that are covered in the next three talks. So let me move on. And I should have mentioned at the beginning, I think given the time, I think we'll have all of the talks go, and then we'll have the panel up here for questions at the end, if that sounds okay. So let me see if I can figure out how to move next. I will introduce as our next speaker Jeff Gerber, who is from the Children's Hospital of Philadelphia. He is a assistant professor of pediatrics in the Division of Infectious Diseases. He is also the director of antimicrobial stewardship for the hospital, and a real national and international leader in the area of antimicrobial stewardship. So, Jeff.
Thanks so much, Ed, and everyone for coming today. So, as Ed said, I'm going to talk about the role of antimicrobial stewardship, something you may or may not have heard of, in addressing the issue of antimicrobial resistance. So, I'll try to define antimicrobial stewardship. I'm going to focus more on why I think outpatient stewardship, Ed mentioned inpatient stewardship, or why I think outpatient stewardship is important, and then talk about highlight a few interventions, example interventions that occur in the outpatient setting. So we use a ton of antibiotics, and antibiotic use drives resistance, as I've said. And use is typically the metric that we use, the outcome that we use as a proxy for resistance. And it's recently accepted, although it does represent somewhat of a gap that we have to get better at. And antibiotic-resistant infections are hard to treat, and they cause a lot of harm and mortality. The CDC report shows that at least 2 million people are infected with antibiotic-resistant infections each year in the U.S. At least 23,000 die. These are probably vast underestimates. And 250,000 people are infected with something called C. difficile. If you haven't heard of C. difficile, it's a bacteria that lives in your gut that can cause really bad infection, even death, and it's typically preceded by antibiotic use. So this is a big problem. And although we're focusing on resistance, there are other harms that antibiotics can cause, including direct adverse drug effects, allergies, other bad skin reactions, and something we're just starting to recognize is that our microbiome, or the trillions of bacteria that live in and on us, most of which are in our gut, play a key role in metabolism and education of our immune system. And there have been some associations now between the makeup of your gut microbiome and when this becomes dysfunctional, some relationships between chronic disease states. And so this poor child is doing the best they can to work on populating their gut microbiome, and we don't give them Augmentin or a Z-Pack, and they have to start all over. So there really are harms even beyond antibiotic resistance. We need to pay attention to. So what can we do about this? So CDC doesn't just paint the gloom and doom scenario about all the harm. They do have sort of a 4-point plan to address the problem of antimicrobial resistance or antibiotic resistance. And they're listed here. So preventing infections, infection control, tracking antibiotic resistance, developing new drugs and diagnostic tests. But number 3, which I think is the most important, really is improving antibiotic prescribing or stewardship. And they talk about, there's a nice free online guide to some of the evidence behind this effort. And so what is antimicrobial stewardship? There are a lot of different definitions. This one's kind of wordy, but I think it captures much of many of the important concepts. So it's really about the optimal selection, dose, and duration of antimicrobial treatment that results in the best clinical outcomes. It's really about optimizing use for the best outcomes, not just rationing use to prevent resistance. And then when you do that, you will prevent infections, improve outcomes, and minimize toxicity of the patient, including antibiotic resistance. These are stewardship programs, are really quality improvement initiatives that have been proven in multiple studies to improve patient outcomes, as I said before, to shorten the duration of hospital stay, to reduce infection with this thing called C. difficile that can wreak havoc on the body, reduce resistance, as I said, and they actually do save money. Again, not just for rationing antibiotics, but it really ends up being better treatment. You're optimizing outcomes, so you reduce the time patients are in the hospital. You sometimes reduce unnecessary tests and unnecessary side effects. And the saving of money is actually a big draw toward hospital programs and public health agencies. So, as Ed mentioned and I alluded to, the core focus of stewardship has been on the inpatient setting. And the strategies that people use, there are a lot, but really it's 2 different things. So prior authorization, so actually being in the hospital and requiring doctors, frontline clinicians, to get prior approval to use certain antibiotics, some of the more expensive or what we call bigger guns, the ones that are very broad in spectrum that we like to reserve as sort of sometimes emergency last line agents. Another approach is something called prospective audit feedback, where you may let people prescribe whatever they want, but after 48 or 72 hours, when you have more clinical information, more diagnostic information, you can then either stop or de-escalate or tailor your therapy with the appropriate dose and duration and spectrum of activity. But as I mentioned, this really happens in the inpatient setting, and it's now recommended broadly for all acute care hospitals. But that's not the only place where antibiotics are used. And this is a little bit of a digression, but I am from Philadelphia, and this is an aerial view of Philadelphia. In the foreground, you can see Eastern State Penitentiary, which used to be a famous prison that was opened back in the 1800s. It's now actually a great museum. And the reason I bring it up is because it's famous for having housed some of the most famous criminals in the U.S., including Al Capone, and this man, who is Willie Sutton. And Willie Sutton is a famous bank robber who, when asked why he robbed the banks, he said, well, because that's where the money is. And I use this analogy along with, to talk about stewardship. More than 90% of all antibiotics are used in the outpatient setting. So I think, well, it's something to say that's where the money is. And if you want to perform stewardship, you really should focus on the ambulatory setting. I think more and more people are moving toward that, and we've tried to do a lot of that in our center. So some evidence of this, a fairly recently published study by Lori Hicks and folks at CDC show that using this IMS health exponent database, which essentially captures 100% of pharmacy dispensing of antibiotics in the U.S., we use a 250 million antibiotic prescriptions per year in the U.S. alone. That's almost one prescription per person per year in the U.S. So it's a lot. I'm a pediatrician, as I said, I work at Children's Hospital of Philadelphia, and so if you look at kids, it's even more dramatic. Here are the top 6 most commonly prescribed medications to children. So the big ones, asthma, ADHD,